Hi everyone, this is Dr. Brian Glass, and this is the Diabetes Voices of Strength podcast. Today I have the absolute honor of sitting with one of the giants in diabetes care, Dr. Camillo Ricordi, here at the Diabetes Research Institute in Miami, Florida, part of the University of Miami. And so it's a real pleasure to meet you, Dr. Ricordi.
Thank you for having me. I'm happy to meet you too.
Yeah, absolutely wonderful. So let's start at the beginning. Let's talk about Go take us all the way back and what got you involved or interested in diabetes in the first place.
So all the way back, I was born in New York, as you can tell from my accent.
Of course. Yes.
Grew up in Milan, Italy. And at the end of the high school, I was lucky to get a perfect SAT score and could go pretty much everywhere. So I wanted to do astrophysics originally, but then I read a book by John Eccles, The Understanding of the Brain, that summer. So I switched completely, said the brain is our universe and I prefer to study neuroscience. Then when I went to medical school in Milan, my little cousin was diagnosed with type 1 diabetes. And so it became a family mission, and I said, okay, forget the brain for a couple of years. Let me cure diabetes. This was like 84, and then I'll go back to neuroscience after we cure diabetes. So it took a little longer than 2 years, but it was quite an experience because I first started developing the invention of the Ricordi Chamber automated method. Was actually formulated in Milan at San Raffaele Hospital, where I trained and graduated in medical school. But we didn't have the resources. They put me in a little corner in the pathology where they were doing autopsies, and we didn't have any resource. So my boss, the professor, told me, well, we don't have a budget for islet, but if you wait midnight and you go to the central laboratories with a cart and a veil, then you can pick up the solution that you may need, steal them practically, and then go back in the early morning and do your experiments. And so after a few months, I said, we're not going very far with this kind of support and infrastructure. And I was lucky that I met at a congress in Austria, in Eagles, Professor Paul Lacey, who was the master and commander of islet transplantation pioneer that developed the methods in rodents years before. And he accepted me at Washington University in St. Louis, where I moved for 3.5 years. And but in those days, was really primitive. The islet isolation procedure were all very traumatic, mechanic, like a food processor, meat grinders, Velcro, needles of decreasing size passing the pancreas through. Because the challenge between 1964, when the first microdissected islets were extracted by Hellstrom, to 1985, was pretty much, we were not going anywhere as far as amount of intact functional islets that you could retrieve from a pancreas. And my hypothesis was, since to capitalize on the fact that 98% of the pancreas, the exocrine component, is reached through the duct system that drains in the duodenum. But if you go backwards, you can expand like a tree, the whole organ, without touching directly the islets that are only connected through the vascular system. So you have practically the 1-2% precious load of these hundreds of thousands microscopic structures are spread out through the organ, and is very difficult to be able to take them just based on a mechanical action. But if you perfuse the organs with this enzyme blend and put it in a chamber where you can start a flow, a continuous flow, where you slowly activate the enzyme by warming up to 37 degrees and activating these enzymes. They would disassemble progressively the organ, and so you have a screen retaining the big fragments, and the size of the islets can pass through the screen and be saved in another compartment where you inactivate the enzyme by cooling and dilution. Then you have a last step of purification, and then you have this few drops of precious load that you can resuspend in a blood transfusion kind of bag and infuse in the liver, typically with an outpatient procedure in local anesthesia, putting a small catheter to the vein that goes to the liver, the portal vein, and in a way you re-engineer the liver to become a double organ that does both the function of the pancreas, endocrine pancreas, and the hepatic function. So I call it organ engineering 1.0 before genetic engineering. So it's a more primitive way to engineer organs. But it was fun in a way because when I arrived in St. Louis, there was the engineer of McDonnell Douglas were working with Paul Lacey's team, and they were patenting a method that was based, I found out later, on a meat grinder that was covered in this stainless steel box, so nobody knew what was inside. But actually there was a hole here and a hole here.
Okay.
And you put the pancreas on one hole, and then this mesh things came out from the other one.
Like they were making burgers or something. Yeah.
Something like
yeah.
But when I presented the research team the idea of having a continuous flow chamber and islets coming out from the outlet, everybody started laughing, saying, yes, sure, you put a pancreas in a chamber and then islets pop out on the other side like magic. So it was put for 1 year. I worked on other projects, but I would still go to the slaughterhouse, the pig slaughterhouse in East St. Louis to get porcine pancreas and try to work behind the open sort of semi-reserved on this concept, building the first chamber with like $30 equipment like fan well filters, instead of putting like this, rotating like this and replacing the filter to sterilize solution with a mesh of the size of desired size. And then suddenly 1 year later there was on a Friday evening a pancreas arrived to be processed with the McDonnell Douglas kind of meat grinder, and was too old. There was 18-hour cold ischemia, so the team, in part because it was a Friday evening, in part because said it's too old, we are going to waste the solution, the resources, it's expensive to do an islet isolation. So they dump it in the bin, the biohazard trash bin. And so I said, this is an opportunity. I'll stay a little longer. I wait for everybody to leave the laboratories and pick up the pancreas from the trash, and I stay up all night to test the method. And I said, if it doesn't work, I will not say anything to anybody. And then since it was working quite spectacularly, I called Paul Lacey Saturday morning and I said, you should come see what I got. And then he came to the lab and looked at the microscope at the islets, and I saw his skin color started turning from white, pink, red, purple, was all excited, and I started calling the chairman of surgery, chairman of pathology. I had all these people coming to see the microscope, and that is when I realized that we obtained something unprecedented, and within 2 weeks the McDonnell Douglas engineer left, and they abandoned the previous patent and developed this method, and then with the help of all the team to bring it to CGMP, sterile condition, and so that was quite an experience. Then I go back to Milan because I said, okay, I developed the method, now I can start the transplant at the University of Milan, San Raffaele Hospital, set up the CGMP, the cell factory there. And then my boss said, we cannot, why should you succeed first? That nobody succeeded before in islet transplantation. We should meet. Let's wait at St. Louis or Minnesota or Miami will start, and then we'll see how it goes. So they got cold feet at the last minute. Say, wait a minute, I spent 4 years in St. Louis, I come back, set up the whole system, and now you say, wait. I was completely upset.
Sure.
In the meantime, I became a tenure assistant professor in surgery. I started on my tran, and then one day, 1 year later, I was making rounds in the Department of Surgery, and the head nurse called me and says, there is a certain Professor Thomas Starzel that wants to talk to you. And I froze, because for us, Thomas Starzel was the god of transplantation, developed liver transplant, all the other breakthrough in transplant from the University of Pittsburgh Transplant Institute. And he told me, first I could barely talk, and he says, do you speak English? Because I says, no, I didn't expect your call, sir.
Sure, you were shocked.
And I was like shocked. And then he says, I spoke with Carl Gustav Groth, that was then the chair of the Nobel Assembly in Stockholm at the Karolinska Institute. And I asked him, I said, I want to start an islet program. Can you give me a list of the top people that could start the program? And he provided him a list of 10 names. I happened to be the first name, but Starzel told me immediately, I have no time to waste. You have 24 hours to decide and 1 week to move to Pittsburgh. Should you accept this mission?
Wow.
And I said, wow, I spoke with my boss and all the leadership of the Department of Surgery, and he said, are you crazy? You just got the tenure position in Milan in the round table of the top surgical team in Milan, and you leave for a 6-month visiting assistant professor, like make it or break it. So if this work, you can stay in Pittsburgh. If not, you have a 6-month contract and pack your bag and go back. So I took it, of course, and
fortune favors the bold, as they say.
Yeah, calculated risk. Well, I knew that the procedure was working, but the fascinating thing was that I arrived in Pittsburgh before Christmas, with the Christmas holiday, whatever, that don't exist in a transplant institute. But I was still unpacking, setting up this little room of laboratory that was for sure not CGMP, not what became then FDA requirement later on. But on January 10, actually in the night of January 9, Starzel called me and says, we have a pancreas for you. And I said, well, but we're not really ready. We have still to test all the equipment, the thing, we're setting up the lab. And he says, no, we have the organ, I don't want to waste it. You just show me what you can do and give me the islets in the operating room tomorrow. I said, all right. So that was the first successful allo transplant of a series that was then published in The Lancet later that August. The first transplant was January 10, 1990 in Mary Arthur, a girl, 15-year-old, and then followed by several other transplants, all successful, and was a game changer. I started receiving calls from all over the world, and then San Rafael in Milan said, okay, we're starting, and in March they did the first successful transplant in Europe. And then the rest is a little history, but
it's amazing, and the amount that you do at night is also stunning.
Yeah, I did. I have a reputation for not following orders and being a little disruptive. Like we had another episode that is important. That was this soldier wounded in Afghanistan. Trepor Furio was 21-year-old. Was shot in the back by someone he was training, was a sleeping cell within the training program, and he shot with 3 high-velocity bullets in the back, and was airlifted to Germany first. They removed half of the pancreas, multiple surgery, then was airlifted to Walter Reed Army Medical Center in Washington, and the head of surgery at Walter Reed called me, say, we can save a piece of the pancreas, can you process it, extract the islets and send us back the islets? So we try to save this person, this patient, this soldier, airman, from diabetes, the most severe diabetes. When you remove the entire pancreas, you don't have also glucagon counter-regulation, it's much more common. And I said, well, I don't know what we can get from half pancreas, but we can try, but let me ask. Then I asked the University of Miami regulatory officials, and they said, no way, you cannot do this because you don't have FDA permission. They never try shipping islets. They never did an islet transplant there. You would have to do it through telemedicine. and it's a high risk for the university. And so I said, okay, so I let everybody leave. It was the day before Thanksgiving, the evening of Thanksgiving. So everybody leaves like before 5 or 6.
Right.
I call, says, send the pancreas from Washington, arrive in the night. I process during the night again and send the islets back, and the soldier, the wounded airman, was completely off insulin within days. So then it became the national news, and then NIH annual report included this as an example on how you well spent taxpayer money, and of course everybody was happy, or a celebration, and but that tells you, if you don't take calculated risk, if everything goes wrong, then you have the Miami Herald Professor Ricordi kills wounded soldier doing experiments with a non-FDA approved procedure.
Right.
Experiment on a wounded soldier would not be very popular.
Right.
And
but it worked.
So
and it's all positive news instead of potentially negative news.
But if you're not, there was a very nice editorial on Science years ago that says the willingness of take a calculated risk and what sometimes make you advance in breakthrough, because if you work only on the rule and performance of indicator of risk avoidance, then the best thing to avoid any risk is to do nothing.
Right.
And you block.
Right.
Which was in the past what FDA interaction with me put so many, raising the bar of the regulatory complexity, but now it's changing because they realize that China, Japan, Australia, South Korea, Europe, Canada are leaving us in the dust because they're moving much faster with new experimental procedure, testing new potential breakthrough, while we still have to be regulated like a last century regulatory system. Like that's all our battle now, to regulate islets like organs, like in the rest of the world, instead of drugs.
A huge
that
travesty.
imposes a huge,
that needs to be completely overturned right now.
I hope so, because I mean, I'm happy because they're all my students in a way worldwide. We train everyone from Australia, China, Europe, Canada, the Edmonton team first, and then many others. And France now is approved as standard procedure and reimbursed. They did over 300 transplants. They send me a wonderful video. I'll send you the videos that I received from all over. James Shapiro from Edmonton, China. But it's a pity to think that we developed here in the United States. The UK network approved it based on our results done on US taxpayer, and without even needing to do another phase 3 trial. So no, what you did is enough, approved. And here instead we are not. It's ridiculous for our patients, our academic centers. It's like you're going towards the finish line, you train everybody else, and then you're slow, then boom, France,
they fly past
here,
you.
Canada here, China here, boom, boom.
Right.
So my campaign has been like make America competitive again, because
I love it.
in this in biopharmaceuticals and in health span strategies, that is another field where we are trailing the rest of the world with the shortest healthy longevity. That's
amazing. And of course, it's now, this year is the 40th anniversary of the Ricordi Chamber, which is what Dr. Ricordi has just described as making it possible to isolate these islet cells without the meat grinder technique. And we have a Ricordi Chamber here. We have a few of them.
Yes.
Yeah, and so it's
from the very first one there. That is.
Yes.
So this one was, in the old days, you had to make them from a piece of stainless steel solid and were carved one by one, and then you could re-autoclave and sterilize. But by doing this, you cannot see through what is happening, so you just have to take samples from the outlet and check. Well, now it's much easier with the new chambers. You can see through and have a better
That's amazing.
assessment.
Yeah, and it makes all of the cool things that are happening right now possible.
Say because they say, your invention 40 years ago, but actually it's like the global impact still now because of
That's
the
right.
Eledon trial, if you do the gene editing trial with pancreas, everything that is using a pancreas, the donor pancreas-derived islets, is done using pretty much this technique, and then hopefully one day we will have stem cell unlimited sources of insulin producing cells, but not so fast because so far now we have thousands of pancreas from multi-organ donors available, which we are not using because of this obsolete last century regulatory system.
Right.
But the potential is there, and then hopefully stem cell derived sources will be able to do as well as good or pass islets, and then we can go to sleep without having to stay up in the night to process pancreas and do transplants on demand.
Exactly. So how would we get that changed? Who changed that? Is that the FDA?
Well, HHS, like Secretary RFK Jr. could do it
right
with
now.
one letter right now because they can be grandfather, like composite transplant have been grandfather, cord blood, bone marrow transplant are not classified as drugs, but for some islet transplant from pancreatitis, you do an auto transplant, you can do it freely. And then the same procedure with the donor pancreas, boom, block completely. You have to go through IND, and now thankfully we have permission to do 10 patients with the Eledon new trial between Chicago and Miami, but you're expanding 10 more patients in the next year or two, while China is doing 310, France 310.
Right.
Edmonton doesn't even have waiting list anymore. And it's not just patient access, to expand patient access, it's also the ability to test new breakthrough procedure towards elimination of anti-rejection drugs, for example.
Sure.
Because if you can do them and test, like China has this dual track. You have the FDA track, the China FDA with the IND, BLA, like we have here, but they also have the IIT track that is based on ethic committee and local healthcare regulation,
Okay.
Minister of Health regional, so that they say you propose, is reviewed by committee, if it's safe enough, they let you explore 12 patients, 20 patients, and then if it is promising, you move to the more strict requirement before you give it as a global solution, of course. But by doing this, now China can do 10 times more clinical trial that we are exploring new technology, and then when they find some, you de-risk the procedure before you have to invest a lot, and you can move. That's why they're leaving us in the dust, pretty much.
I remember when I was in graduate school at Cambridge over in Britain, and there would be new glucose testers that would come out on the market well before CGMs, and they would have them there, and yet they were made by American companies, but yet you couldn't get them in the United States. And I was sitting there, just racking my brain as to why is it that it's being invented in the United States, it's getting approved over here first, and then it could be months or even years later when it finally gets approved in the United States. So obviously our regulatory system is very convoluted, and maybe it's just afraid of lawsuits. I don't know.
No, are the performance indicators when is risk avoidance?
Yeah,
because if
nothing.
something happen, you're on the spot. But nobody counts that we're losing one patient every 9 seconds by delaying a cure.
We're losing one patient to type 1 diabetes.
To diabetes in
just
general.
Diabetes in general every 9 seconds.
And
Did not know
it's
that.
like 3.4 million worldwide a year, but it is, and then if you look the accelerated aging and the shorter lifespan, there was an important article on the Lancet Diabetes Endocrinology showing that in United States, a diabetic child diagnosed at age 10 loses an average of 13 years of lifespan, but the average worldwide is 24 years. And if you are in a low-income country, a child 10 year diagnosed loses 47 years average compared to someone without diabetes. So it's clearly a condition of accelerated premature aging, like many other inflammatory-based chronic conditions.
Sure.
But it points out also the disparity of economic access to the technology, because this 13% in the United States, I don't want to scare anyone. If you're lucky that you can access the best center and technology, CGM and algorithm, you're okay. But then you have the other part of the population that doesn't have access to all of this. Even in the United States, there is a lot of disparity.
Sure.
They were telling me, like, we don't have to go to low-income countries. In Chicago, there is from one zip code to the next one. You may have 10 years difference in lifespan or healthy lifespan. So it is elements that should make us think, what can we do to improve access and don't slow us down and make us competitive again, so that we can continue to contribute. Like in '85, when I came first to Washington University, this was the place to make things happen.
Right.
When I went to the Pittsburgh Transplant Institute, Thomas Starzer, boom, 2 weeks, we could do the first islet transplant and show a new strategy that then was an example for the rest of the world. And now, instead, if I have to test something new, I have to wait 6 months to a year, go and meet all the strict requirements for regulatory to even start a pilot trial. So we have now a new strategy with high tolerance, with this fast ligand microgel to intercept cells that come to reject the islets and induce immune tolerance. We did spectacular preclinical testing in preclinical model, ready to go, and then the feedback was practically we would need $15 million to just get to the moment we can start to do a patient. So I call China, Shanghai, and says, how much would it cost if we do this IAT dual track in China to start to show if it is working or not. Then if it is working, we can find the resources to do it also in the United States.
Yes.
And they told me, well, it's around $70,000 per patient, including pancreas procurement, which here just to get the pancreas in the lab cost you $50,000 to $90,000. So that they do pancreas procurement, islet isolation, islet transplant, follow-up for 1 year with the transient immunomodulation, everything for $70,000. In France, is reimbursed at 47,000 euro per transplant. But here, that the problem of cost is another that we'll have to address after we are successful with the reclassification to organ, because there is no way in hell that the pancreas should cost you that much just to get to the laboratory.
Yeah, that sounds insane. It really does.
Yeah, especially if you think you're a non-profit system.
Right. So let's transfer to the Elodon trial, which is currently ongoing. I've interviewed Katie Beth Hand already, and she is one of the first 12 patients to undergo the transplant, and she just announced on her Instagram last night that they're going to fund 3 more, which is fabulous news. But tell us more about the Elodon trial, and maybe you could put in perspective for us how much it cost to cure, or to do the transplant for each one of those first 12 patients.
Yeah, well, actually, the Eledon Trial has been a game changer because you have a much better immunosuppression. There is confusion because it's not a cure, like you still need chronic patient immunosuppression, but it's less toxic. You're eliminating the worst immunosuppressive agent that can cause a problem to the kidney, neurotoxicity, and is diabetogenic, can induce diabetes in people that don't have diabetes. If you get a kidney transplant and you're non-diabetic, and with this drug you can go on insulin and become diabetic in a series of patients. So to have to use tacrolimus, to have to use a drug that you need to keep the islet alive but can induce diabetes is not the ideal kind. So we've been working on anti-CD40 ligand, that is the monoclonal antibody, since the 90s here at the Diabetes Institute. And we
interesting.
did all the preclinical studies, first for Biogen, then Biogen shut down the program because they had problem of thromboembolic complication in kidney transplant. In islets, we didn't see it because we use heparin in islet, so you anticoagulate when you do the islet infusion. But in kidney transplant, there were some side effects, and they stopped completely. So then I went to a post-JP Morgan meeting to explore new potential breakthrough emerging, and I discovered, I was at this presentation, this little advisory board of this little company, Analyxis, with Steve Perrin presenting. The data was a spin-off of the ALS Foundation to cure ALS, and he said he was working at Biogen before and spent 10 years to re-engineer the antibody crippling the Fc receptor so that no longer activate platelets, so there is no more the side effect in coagulation, but retain the biologic function of the blocking co-stimulation, that is the second signal that is necessary to start attacking a transplanted organ. So I said, wait a minute, forget ALS. So I mean, no, don't forget ALS, but we are back in the game with diabetes. And and he said, well, we don't have the resources to do in diabetes. I said, what if I help you raise funding for islet transplantation for diabetes, so that we agreed to move in this direction, and I had a massive effort to raise many millions of dollars to start the program. Then Analyxis became Eledon. Eledon becomes listed in NASDAQ, and the new CEO, new board, and they decide that kidney transplantation is more commercially appealable than islet. So for years we were blocked, and I was saying, cannot believe it, after all what you raise from people with diabetes. And luckily it turned around, because then Piotr Witkowski in Chicago had an IND approved. Elodon was willing to give the drug, but not to fund the trial. So with my little foundation called the Cure Alliance, that is sort of a Spark Foundation, we don't have millions, but we can provide a few $100,000 to do the first attempt. I convinced Breakthrough T1D to fund 50-50 the first 3 patients with the Cure Alliance. And we provided assistance, and we've been collaborating from day one with Piotr, doing all the immune monitoring here in Miami. And then now Breakthrough T1D has been fantastic, funding the next wave of transplants. And now we just got approved to do 10 more transplants in people with chronic kidney disease. At the initial stages, because before with tacrolimus you couldn't touch someone if you start having sign of diabetic nephropathy.
Right.
But this affects 1/3 of adult patients with diabetes, so you cannot. You're
limiting
you have to eliminate people that need more than 45 units of insulin. People with kidney initial sign of nephropathy is like, and now instead we don't have that limitation, because with this, since this drug is not diabetogenic, you can transplant people that require more. We had patients with over 90 units of insulin a day transplanted, and now of insulin. And
is that both basal and bolus, or is it?
Yeah, if you have before the limitation was like 1 unit per kilogram, or maximum 45 or 55 units in some trial. But now there is no limit practically, because so far all 12 patients have been off insulin.
Yes.
So, and the other important thing is that the kidney transplant trial that is going in parallel has been showing incredible effect on preserving kidney function. So you have the eGFR at 2 years, that is 18 months, that is improving, while the Prograf tacrolimus arm is decreasing, and there is a significant difference. So that validates also in another organ transplant system, this is the right path to do something that is less toxic.
Right.
Less toxic immunosuppression, not a cure, but functionally you're off insulin, and if you eliminate progressively the side effect and develop immunomodulation technology that is safe and effective, is a significant step in the right direction.
Yeah, that's fascinating. Also, the fact that it was funded half by your Cure Alliance and half by Breakthrough T1D. Now tell me if I'm misspeaking here, but wasn't the Diabetes Research Institute originally funded in part by Breakthrough T1D?
I've been funded since I was in Leslie's lab. So in fact, I will be speaking at the Breakthrough T1D Clinical Research Congress in October on the 40 years of the Ricordi Chamber automated method and what was enabled by these 40 years of continuous support. We were also funded continuously in the last 25 years by the Diabetes Research Institute Foundation for all these anti-CD40 ligand preclinical trials and Norma Canyon and everything. So it's really a teamwork. Like I don't single out any foundation, but of course Breakthrough T1D has much bigger power of funding behind, and they started also the T1D fund to support companies. The Cure Alliance is a little spark foundation. When I have an idea, like in the COVID trial, we wanted to transplant stem cell and save people intubated in the ICU. We did the fundraising through the Cure Alliance. Boom, we got the support to start. But we can just do the spark, show that something works, and then other foundations come in and support more. So the DRI Foundation is the one that allows us to test every year, flexibility to test new things. Then we develop the new pilot, and then we can go and apply to NIH, Breakthrough T1D, or others. And then the Cure Alliance allow me to do things worldwide. Like if I can do a trial in Chicago, I couldn't do it with the budget of the DRI in Miami. They were saying, wait a minute, we have all this project waiting in Miami. There are not enough funding. Locally, I cannot give the money to another institution. But if you go instead of what is the priority to advance in the fastest, most efficient way possible towards the cure, doesn't matter where. It's like what is more interesting, what is more appropriate, what is more timing in that moment, and that was Chicago.
Fascinating. I actually, when I lived in Chicago, I was a patient. I had my endocrinologist was at the University of Chicago.
Great.
I don't remember now. This has been 20-some years ago. He was a type 1 diabetic.
Okay.
I know that, and he had made it to base camp of Everest. So if he's out there and he's watching this, please reach out, because I'm sorry, I don't remember your name. But yeah, I mean, you go where you have to go, but it sounds like it's very much a collaborative effort.
Definitely,
all the way around. So Diabetes Research Institute is, as I understand it, it is the only diabetes focused lab in the country that is, the main focus is type 1.
Yes.
Yeah.
Now there is more and more overlap with type 2 because, beta cell regeneration, inflammation is more and more a gray area, the passage type 1, type 2, and obesity now increasing also type 1. So you're understanding all the mechanisms that are shared as challenges and also as opportunity for success and developing new strategies. But this has been the mission, is to cure type 1, and then with benefit that will help also type 2 for sure. Because a lot of people in type 2 has insulin requiring.
Absolutely. What, in terms of, I mean, I know that the current Elodon patients are having to go to Chicago every 3 weeks to get a new infusion.
Yes.
What are we looking at? What is kind of the future prospect for this being something that can be done more locally if there are more patients?
This is already developing because now there will be the subcutaneous formulation, like the Ozempic kind of pen of Mounjaro. So that will be a big breakthrough to pass from the IV infusion to the opportunity to do it also subcutaneously. Will make it much more accessible. And I know Eledon is already working. They already actually started the trial to. I think by the end of the year or 2027, patients will be offered the opportunity to switch to subcutaneous.
Sure. Well, put on your Nostradamus cap for us for a second. And like, best case scenario, where do you think we are with, not curing type 1 diabetes, but making type 1 diabetes treatable without insulin, say in 10 years time or 20 years time, just so that we kind of give.
I don't have that much time. I need to do it.
You need to do it even sooner.
I need to do it sooner, but I've always been saying it's 5 years away, the cure, for a long time. Like when I went to St. Louis at the beginning,
Right.
my boss was saying, go there because there will be the cure unless you can do islet transplantation and cure rats and mice. So we don't want to miss the chance to cure diabetes in Europe in the next 5 years. And then since then there has been this myth of the cure 5 years from now.
That's right. All of us diabetics are always talking about that.
And
Yes.
it's been 40 years.
Right.
So that, but you know what I always tell the team is like you always work with enthusiasm and intensity, like the cure is the next possible. What we are doing now, the high tolerance with the fast ligand to induce tolerance and eliminate all immunosuppression that is already working in preclinical studies. If this pilot trial that unfortunately, or fortunately actually we can do in China, is working, will be a tremendous breakthrough. Sonia Schreffer now, that was Sana, left Sana to work with me and James Shapiro on a new gene editing platform to make hypoimmune cells that can be transplanted without any immunosuppression and protect from autoimmune recurrence that unfortunately the Sana platform doesn't protect you now because you cannot have zinc anti-8, for example, or other this antibody that is autoantigen that is very frequent. But if one of these things work, we are in a different ballgame, you know, then you're really going to talk about a cure. Now I'm helping also New X that just signed the agreement with Eledon to be potentially the first stem cell derived islet company being able to use the Tego immunomodulation, immunosuppression, and I just joined their advisory board a week ago to help them move the technology to United States and hopefully start the trial in a year or so with the Tego with the anti-CD40 ligand monoclonal. So that will be a big advancement because I'm helping everyone and their sister in the stem cell field, not just New X. I'm also on the Vertex steering committee.
Right, yes.
We're doing the principal investigator of the Miami site. But I'm trying to convince everyone, don't stick to Prograf and tacrolimus. You're going to, you know, is a boomerang that sooner or later this transplant may not do well over time, and I'm sure they're thinking about switching and developing new technologies. But to me, it's also a combination therapy. There is not a single magic bullet because the moment you have a successful islet transplant, you have to start thinking prevention of disease recurrence after an initially successful cure. So when I see my friends from Chicago or posting on social media, I don't have any more insulin, my hemoglobin A1C is 5 point something, now I can eat pizza and ice cream like there is no tomorrow. So, not so fast.
Not so fast.
Now you reset the system, you have a new opportunity at life without insulin.
Right.
Don't mess it up because it's the same problem that this chronic disease pandemic, including type 2 diabetes. You don't want to convert type 1 in type 2. Insulin resistant is still behind the corner if you do the wrong diet, if you don't exercise, if you don't apply all the healthspan pillars that I wrote 2 books for this, the healthspan code and therapeutic revolution, to try to address this
We will link those here, yeah.
And I'll send you the PDF.
I did, yeah, I saw that. That's fantastic, thank you.
And but it is so I think we really have to work against the tsunamis of chronic diseases that if you take diabetes as overall, like I can do 100 transplant, 1,000, 10,000 transplant a year. In the meantime, diabetes grew from 171 million in 2000 to 590 million today, projected to become 850 million.
It's insane.
In 2 decades. So it's like curing a pimple on an elephant that grows.
I know. Yeah, I mean, diabetes is the plague of our times, and I think.
But it's not just diabetes. Chronic kidney disease is twice as much. It's 850 million already worldwide, and cardiovascular diseases, neurodegenerative, because our lifestyle and diet and environment are not helping. No, we were very good to treat with reactive healthcare systems with antibiotics. We have infection, viral, some severe disease, and you have this incredible technology that costs more and more, less and less accessible by all,
Right.
and are already costing 18% of the GDP of the country, $5.3 trillion a year. So in a population segment that will double in the next 2 decades, so what we do, 40% of the GDP in healthcare, you have to start thinking, how do you evolve from a reactive health system to a proactive, predictive, preventive? Not that you abandon, you don't abandon who is sick, you still work on advanced cell therapy and cures, but you have to slow down, mitigate this plague of the tsunami behind you, otherwise
That's
you'll never
right.
win as a healthcare system.
Yeah, the tsunami will eventually crest, and it will
Yeah,
crash
it's
down on all of us.
And it's actually what you can save with prevention and health span. Every year you add to healthy lifespan, you can save 38 trillion to the global economy. So if you think what you could do with the resources that you save, you can invest more in advanced therapies for those affected. So my plan philosophy is like 4 levels of intervention. One is predictive diagnostic to prevent and intercept risk factors before they evolve to a disease.
Sure.
So in type 1, you don't have to wait to have autoantibodies or failing islet function to do the intervention trial in stage 1, 2, or 3 of diabetes. What about stage 0?
Yes.
When you're like walking out like you don't know anything, but if you test, you can intercept risk factors, say, wait a minute, your regulatory T cells are going down, your inflammation is going up. Now if you have a triggering event of autoimmunity, you don't have the same ability to mitigate that factor. If you think vitamin D alone can decrease 39%, almost 40%, all autoimmune diseases, it says, isn't that something to consider, to don't have low vitamin D?
Yeah.
Like in breast cancer, for other pathologies, but what is the problem? That you can get on Amazon vitamin D for $19, 2 years supply, so there is no billion-dollar molecule behind or big profit. And in a way, if we want to engineer health span or make American healthier, I don't know the again where it comes from, make America healthy again, assume that you were healthy before, but
Right.
But you know, we did improve lifespan, so you cannot say medicine didn't advance. You can, but now you can keep people alive much longer at cost that will become economical and sustainable and bring to the collapse of health systems that are exclusively reactive. That's why we really need to work in all the direction. That is prediction to intercept and prevent, and then early intervention trial at the early sign of disease, curing those already affected because you don't leave anyone behind, like in the battlefields, and then 4th level, equally important, prevent disease recurrence after an initially successful cure. Then you close the circle.
Absolutely. Prevention and early intervention as opposed to this reaction.
Yeah, maintaining like the intensity to develop cures for those already affected, but there is no cure without prevention in a way, because it's both. You need prevention before, but also prevention of disease recurrence after.
Right. Well, on behalf of all diabetics around the world, I'd just like to say, again, it's such an honor to speak with you here today about what you're doing here at the DRI and what you're doing for diabetics everywhere in every country with your inventions and your continued innovations. We are incredibly grateful to you, and again, it's an honor.
Thank you.
Thank you so much,
for
Dr.
coming.
Ricordi.
Thanks.